So I'm going to try and explain the complexities by trying to explain how the system went through, what their goals were, and that hopefully explains where some of the changes came from. When we talk about the objectives, the IASLC has taken over this staging project, and it's been adopted by the UICC and the other staging groups, but really it's all being spearheaded by the IASLC. It starts with their database. The database started in 2000, and it's been rolling ever since, collecting patients. And one of the goals with the new system was to make the database more broad-based. The database prior to the 7th edition was a single institution, primarily surgical database. Now it is a multi-continent database, and the goal here was to make it more international, more broad-based, so it better represent everyone. It still is fairly underrepresented from North America, though. Surprising, only 5% of the patients in this database do come from North America. For the current staging system, 94,000 patients were evaluated. After exclusion, 77,000 patients were used. The other thing unique over the last staging system is that there's a lot more prospective data, not just retrospective data. 70,000 of these were non-small cell, but that still means there were 6,000 small cell, and that's the reminder that this TNN system is used for not only non-small cell, but small cell and for carcinoids. I know you're shaking your head. Super early stage, come on. But yes, you're supposed to use it for all of them. It's been validated in small cell, non-small cell, and carcinoid. Keep moving. So when we look at the changes, they look at each category and move through it. The goals with the T stage were to better look at size, location, and atelectasis. Those were things where they thought they could get better prognostication. And so the T component has been further subcategorized by size. So the cutoffs are like easy for everyone now, right? 1, 2, 3, 4, 5. Every single centimeter gets a cutoff. Then greater than 7, each of those gets their own T stage. And what I think is nice about this is that we're actually taking the T1, the 1, 2s, and 3s, and we're really giving people very good prognosis instead of always feeling like we're giving people worse prognosis. Actually interesting here too is the proximity to the carina. So within 2 centimeters of the carina used to be T3, along with atelectasis of the whole lung. Both of those are going back to T2 because not as bad as we thought they were, especially if that still represents resectable disease. And surprisingly to me, involvement of the diaphragm, a totally resectable structure, is moving from T3 to T4 due to bad prognosis. As you can see, survival curves play out really nicely with T1A's survival being 90%, which is pretty impressive. They've once again stressed the importance of visceral pleural invasion in staging. Anything that goes beyond the elastic layer is a PL1, and that obviously ups you to a T2 tumor. If that cannot be determined on H&E, an elastic stain is recommended because this is important in terms of prognosis. Some of the things that are new is they're giving you better recommendations on how to measure subsolid lesions. You know, the part that matters, the part that you stage upon is the solid component on the lung windows. So I know there's a lot about CT ratio and what you see on the mediastinal windows and such, but the recommendation is that you base your clinical stage on the solid component in the lung windows. They recommend writing down the glass component and all that, but this is what that's currently what will be used. Also, they did a little better job of defining what was left after induction therapy. You're often left with a scar, but what does that mean? How do I stage it? Officially, that stage will be determined by the size of the lesion and the percent of tumor on path. So if I have a 3-centimeter tumor and I have no viable cells, that goes to T0. But if I have a 3-centimeter tumor and 25% viable cells, oh my God, I left myself math, 0.75 becomes your new stage. And then also to the T component, we have 2 new T categories, the adenocarcinoma in situ. So TIS used to only be for squamous cell. Now it can be for squamous or for adeno, and you need to appropriately mark that. And then in the T1 component is the T1 minimal for minimally invasive adenocarcinomas. These have come about because of the beautiful work from Bill Travis and the ISLC, ATS, and ERS on better defining the disease spectrum, which is adenocarcinoma now. And so we have very clear, I think, or clearer definitions for what is an AAH, less than 5 millimeters in size, pure ground glass, what is adenocarcinoma in situ, and that is something that's between 5 millimeters and 30 millimeters, pure ground glass, and then finally a minimally invasive adenocarcinoma, anything with an invasive component less than 5 millimeters. Next, of course, they went through, they looked at the nodal component and tried to change that, and they couldn't. That's the good news. They try every year to change the nodal component or each time, and so far to date, they really have not been able to. The current N0, N1, N2, N3 definitions that you all know do give beautiful prognostication. That being said, we do think that there is information within the nodes that can be better pulled out. The nodal map is not changing either with this staging system, so what was put in place last time by Valerie Rush stays in place. Dr. Asamura is working on a more surgical staging map, which will probably change things for the 9th edition. They are trying to quantitate by zone. This is what they did in the last staging system, saying that, if you're a lower lobe tumor and you have right or left paratracheals, that's a terrible thing. And while surgically or pathologically these prognosticate, it really lacks clinical validity. And that's really an important thing with the staging projects, is that anything they change clinically has to validate pathologically. Anything that changes due to pathology needs to validate clinically. That being said, of course, they do make recommendations about some of the nodal disease. We clearly see differences in prognosis based upon the number of involved stations, and therefore they're trying to introduce this N1A, which means a single N1 disease, versus N1B, multiple N1 nodes, and then the N2s into a skip single, N21A, N2A2, which is what? Has an N1 and an N2, or versus N2B, which is multiple. And you can see with the survival curves that there is clearly prognostication here, but it's pretty complicated. So I do think we're a ways away, but I always think that these little suggestions are things that we are thinking about for next time. Next, they were looking at endothoracic spread and oligometastatic spread. We can't just have metastatic disease, of course. And within here, first they looked back at their M1A descriptor to see if there was anything that could be pulled out, anything that could be put back into a T4 type stage. And really, even in this expanded cohort, they couldn't do that. Most of the M1A descriptors really all fall fairly close together. So that descriptor is staying as is. Endothoracic spread is an M1A descriptor. But interesting, they have added a new M1A or an M1B, which is single organ extrathoracic metastatic spread. So oligometastatic disease, a concept which was introduced, 3 or 4 decades ago, and then had kind of fallen away, is really kind of back in vogue right now. This recognition that maybe that person with a single or 2 sites of disease doesn't have the same biology as a patient with widely metastatic disease. And while there are lots of different definitions for oligometastatic disease, for the staging system, it is a single extrathoracic metastatic, to a single metastatic organ. So I do believe 2 lesions in the brain would still count as M1B disease. Both M1A and M1B go into stage 4A. And this is what the metastatic difference looks like for comparing the previous M1A and M1B and then adding the third curve. And you can see that the M1A, the intrathoracic metastatic spread, the M1B, the oligometastatic, is actually quite similar. They've left them separately because they're very different in terms of treatment. And finally, to refine the staging group. So how these all fit together gives us this nice little chart. They give you pretty colors to make you think it's easy. It's not. It's super still complicated, but it's nicely color coordinated here. So you can see we have a couple of new categories here. So there's 1A1, 1A2, and 1A3. So 1A on its own does not exist. We now have 3 of those. The 1B and the 2A has become very specialized. Those are become very small subgroups of patients and highly specialized. Otherwise, all the N1s go together except those that are T3 or T4. And similarly, all the N2s get grouped together again, except for patients with T3 or T4 tumors. I always think this is good because, again, surgeons really shouldn't be operating on patients who have T3 or T4 N2 disease, and making those 3B really does set a nice line. I'm still confused or interested about what we're supposed to do with the 3C patients. Clearly a group with very poor prognosis, pretty extensive intrathoracic disease. I'm unsure how we're supposed to treat them differently than the 3Bs, but it'll be interesting to see how that goes. And then again, the whole M1B oligometastatic disease, I'm actually very excited that those are being separated and pulled away from patients with widely metastatic disease. So some new stages, some old stages, and some patients who have bounced back and forth, you need a card. But the good news is, as you look at the survival curves, both the 24 and the 60 survivals, you see that there is this good splaying of those survivals with overlap. The most significant overlap is between the 3 Cs and the 4 As. Again, so this question whether 3C will eventually become something different, I don't know, but that's where the closest overlap in terms of survivorship lies, and yet those are, again, pretty different patient populations. These are what the clinical and pathologic survival curves look like, and it's impressive. Those upper curves are really fairly flat. We have populations of patients who are, nearly cured of their disease if they are staged at the stage 1A1 or 1AB level. And again, we're pulling the really poor survival out better and better so that we have treatment options for those in between. One more thing which was tackled in this staging efforts, and which there are multiple articles which review it, is our approach to multiple lung cancers. That has always been very confusing and really poorly dealt with in the previous staging system. So in this effort, we ask all of you, when you see multiple nodules on a CAT scan or patient presents to you with that, is that you have to force yourself to put them into one of these 4 groups. So we have patients who clearly have a second primary cancer. So this is usually patients who have solid spiculated nodules, usually in different lobes. Ideally, they'll have different histology. That kind of doesn't happen that often. It would be nice, but it doesn't. But not a lot of other metastatic disease, and each of those gets staged with a T, an N, and an M. Next would be patients who have separate tumor nodules but have, a dominant tumor. The patients who you and your tumor board and your colleagues believe that this is intrathoracic metastatic disease. And those patients should be based upon where that second nodule is compared to the dominant one, the same lobe, the same side, or the contralateral side. That hasn't really changed. And they get a single N and a single M. Next, multifocal ground glass nodules or lipidic nodules. So again, we force you and your tumor board to decide, where does this patient lie? But if this is clearly a patient with multiple GGOs, then this patient is going to get scored with this M number next to them. So you score the largest and most invasive of the lesions, and then you put a number next to that for the number of lesions. So if the patient, its biggest lesion is a T1A1, but they've got 10 ground glasses, it's a T1A1 parentheses 10, and then these are usually N0, M0 with only one. And then finally, pneumatic spread gets staged much more closely to patients who have intrathoracic metastatic disease. We didn't feel like we could put the patients into this group with good rules. We asked, like I said, the treating physician to determine which group they go in, and then from there, we provide the staging recommendations. So, 8th edition, significant changes. We have further refined the T stage. There's no doubt about it. Size matters. New cutoffs, 1, 2, 3, 4, 5, and 7. We've moved the proximal tumors to T2. We believe those are things that are curable. We've introduced adenocarcinoma in situ and minimally invasive adenocarcinomas to the staging system. We left the nodes alone. They prognosticate very well, and there are no changes that are coming in the next 6 months. We've established a new metastatic category, M1B, for oligometastatic disease. And then we have the creation of some new subsets, 1A1, 1A2, 1A3, and finally 3C. I think that's it.